Back, as you say, to that conversation with Minister Zweli Mkhize, the Minister of Health here in South Africa. And South Africa's COVID-19 infection numbers are now heading towards 1.5 million. Minister, thanks so much for staying with us and answering some very crucial questions for us. Now, with regard to the vaccine rollout program, and before we even get into the details of that, you spoke about the first batch of vaccines that will be administered to healthcare workers. But how's that going to work? Is that going to be in one dose, or will it be more than one dosage? And how will that work for the rest of the country as well when we get to that stage?
Sorry, the approach to all the vaccines that were Moderna, Pfizer, the AstraZeneca, the Chinese, the Russian, Sputnik V, and all of them are double doses, which means you get the first dose and then you do a booster dose. The general rule is that the first dose should be, the second dose should be administered about 21 to 28 days. But in fact, the current research has indicated that we can wait up to 42 days, which means up to about 6 weeks. In other words, when we administer these vaccines, we will be administering them. By the time we administer, we will be knowing exactly when the rest of the dosages will be arriving, and therefore we will be administering them as first doses, and then we'll have enough time, about 6 weeks, within which we must actually administer the second dose. The only rule is that if you get one dose from one vaccine, you must actually get the second dose from exactly the same manufacturer. You shouldn't get the dose from a different vaccine because they don't, they've got no synergistic effect that way. And their interaction, cross reactions are not well established. So it has to be one dose. So if you took the AstraZeneca one, you must take the second one. You got the one Pfizer, first one, the booster must be Pfizer, and so on. So they have to be worked on in that way. Except for J&J, where their dosage is going to be a single dose, and therefore there, once you get one dose, that should be enough. Now that J&J dosages will come a bit later in the year, so because of their processes, it's going to be later. So that's not where we're going to start.
And with regard to that, and just going to the pricing, because that obviously is a factor, is there any explanation for the price discrepancy between all the brands?
Well, we don't have the explanation, but the argument is that it's based on the technology. The Moderna and Pfizer are based on a new technology which is called mRNA, which is kind of messenger RNA. In other words, they prime the RNA to be able to create the immunity in the individual without having introduced any aspect of it as part of the viral particle. The others are based on an adenovirus vector, which is using portions of a common virus to actually stimulate the immunity in such a way that it can deal with the features of the coronavirus, but without ever, it being live enough to cause any infectious problems to the individual. So it's a normal technology that they use. The other point which one wants to raise is that I've seen some newspapers who have said that we were not able to negotiate a lower price and so on. They don't understand the dynamics involved in this whole issue of the vaccine. The countries that were asked to put in money earlier, there were two issues about them. Firstly, they had to put money on a kind of blind trust, on a risk hedging, where they would put money for a vaccine they didn't know whether it was going to work or not. Excuse me. Now, that vaccine, if it didn't work, they would have forfeited the money. Then the other issue is that they have argued as well that those countries have put a lot of contribution to the research and development of the vaccine. So whatever amount is ultimately calculated as a cost of the money is not necessarily a good reflection of how much they put into the whole process. In our case, we simply just gone to the price that was determined for purposes of buying the vaccine, which is why, for example, South Africa and Brazil have been paying that same amount of money. Whereas we've seen that the comparison with the other countries sounds like they've gotten less than what we did. Obviously, all of these things are taking place, and we have to deal with information that gets to be made available to us at that level. In some of the areas, of course, they had the advantages of the volumes. In some of the areas, there's also an argument about the sizes of the economy. So we've had a lot of debate about those issues, which is why when we talk about Pfizer, there were reports now to say they were going to drop it a bit lower because of those kinds of debates. So it's a very fluid situation that we deal with. But those are the arguments that get involved in the determination of the prices.
Fluid and very important, both the points that you make, Minister, because we do know there's a lot of disinformation being spread as well. So let's talk about the issue of this new variant. You made the point that those countries that put money up front were basically doing so in blind faith, not even knowing whether the vaccine would be effective. So the question has arisen, given this new variant that has developed in South Africa, whether the vaccines that are currently on the market that were developed for the novel strain of COVID-19 will in fact be effective for the South African variant.
The research is now being conducted to look at the serum of individuals who have already been vaccinated with the various vaccines to see whether it can neutralize the virus, this particular variant. That work has not been concluded, so at some point we'll be able to tell. Excuse me. We'll be able to tell what is the situation. The different countries have speculated what can happen. Some of the manufacturers have also speculated that it may be effective. Others saying it may not be effective. Others are saying it may not be efficient. So we leave that to the science. But whether or not that is the case, at the moment we have to continue with the vaccination program. We will need to, at some point, in any case, look at to what extent South Africa can also build its own capacity to respond to this kind of issue, because we might be facing a problem that might be slightly different to the other countries, and as a result, therefore, we need to also have our own scientists helping us to lead in this way. There are various issues that relate to the vaccines, for example. For example, when we're dealing with the Russian vaccine, a very interesting high efficacy rate and so on. But somewhere along the line, a debate arose with our scientists that they use an adenovirus vector as a technology. Now, they've got adenovirus 5 and then adenovirus 26. Now, the first one is the first dose, the second one is a booster. Now, in some work that was done some time back in South Africa, they found that adenovirus 5 tended to have an association with increased risk of HIV infection. So because of that, our scientists are busy discussing that issue to say, to what extent could such a vaccine affect our situation where the population with HIV infection is so high, therefore the risk might be higher than other countries. So those varieties of vaccines have also got a number of other issues that we've got to delve into to understand what is most suitable for South Africa. So all of these are just discussions that are indicating the detail to which our scientists go to engage those who are manufacturers. At the moment, we are approaching all of the manufacturers to say to what extent would they share research and findings with us so that we can determine how effective their viruses might be, their vaccines might be in eliminating or destroying or neutralizing this current variant. But whilst all of that is going on, the vaccination program has to continue.
And finally, Dr. Mkhize, our own capacity to produce a vaccine, especially now that we are seeing a new variant that's only here in our country. And also, secondly, with regard to Ivermectin, because there's been quite a huge discussion and a debate around that. From your perspective as the Health Department, where are you with regard to your views on Ivermectin?
The first issue you raised about the capacity of South Africa to produce vaccine, there's a debate that has actually come up very strongly. The President has raised the issue with a lot of interest in getting our scientists together. There's already work that's being done to discuss that issue among the scientists, because there has been an ability to produce vaccine before. It was not for humans, it was for other animals, such as poultry and so on. So that work is under discussion. Already Minister Nzimande had convened a meeting with some of the scientists so that we can start the discussion. So as time goes on, we'll be able to talk about that. The Ivermectin, the issue there is that largely the Ivermectin has been used for parasites in animals, worms, scabies, etc., etc. Now, in the process, when the COVID-19 problem arose, scientists were asked to have a look at the numbers of drugs that were available to see which ones could well be applied to fight the COVID-19. Ivermectin was one of those that were identified. So there was a paper that came out, I think Dr. Hill was sponsored by UNITAID, who suggested that there may be benefit from the Ivermectin. And then a number of other papers, research that was done, was actually giving different views about it. But then, of late, we have reports that a number of countries are doing, clinical trials on this, and that our teams are also going to be reviewing again the issue of Ivermectin. There was another review which was done earlier on, beginning of December, where the South African Health Products Regulatory Authority, SAPRA, had actually felt that there still is not adequate information to be able to register the drug, in principle. And however, we are then saying that when these other results come out, we will be able to pull all of this together. Normally what becomes a challenge with a drug is that when you do a trial, you do two things. You administer the drug, and you also use what is called placebo, which means some people will go without the drug. Some people do get better without that drug because of the nature of the ailment that they are going through. And therefore, you need what we call a double-blind trial, that you don't know of the patients you are treating who's got the Ivermectin, who would have got the placebo. Then you must look at the results afterward. When you get those kinds of results, then you are able to say, okay, now we've proven where there was no influence of subjective judgment in this case. So we need to get to that point. But in the meantime, we've said that those who want to register trial on Ivermectin must apply properly, which they will not be denied that. And those who want to order under Section 21, which means the doctor takes responsibility per se for that particular individual and the administration of that medication, they'll have to apply. At the moment, we're not dealing with those applications. We're dealing with a huge public debate where people are sending petitions, are writing messages, and so on. What needs to be done, either institutions, like we've seen some are interested, they must actually register a trial which is in keeping with the scientific standards, which will not be blocked by anybody. And secondly, the doctors can actually apply for Section 21, where the doctor will say, I need this drug for this patient. I will then administer and take responsibility. Then you can deal with it like that. By the time we get the report from all of this other research, we'll be knowing exactly where we go. You recall that there was a similar excitement with the issue of hydrochloroquine, and lots of people were buying the stuff, and some of them actually took it wrongly and all of that. But what really matters is that you can get promising results during the trial, but the outcome has to be recorded with a peer-reviewed process so that we know that we're not putting people at risk. But if a doctor wants to use something, then he has to take responsibility and apply for Section 21. So the process we will wait for. In the meantime, doctors can apply using this channels that I'm indicating.
Dr. Zweli Mkhize, thank you so much for your time this morning. The Minister of Health updating us on both the vaccine expectation and the COVID-19 situation in the country currently. And with that, let's take a quick break before we get into the rest of the show.